everybody. Thank you for being here. We're going to go ahead and get started because we're on a really tight time frame to make every session have the right amount of time. So I want to welcome everybody, and we'll get started in just a minute. My name is Colleen Brock. I'm a registered nurse and the manager of medical programs at the Immune Deficiency Foundation. In just a moment, Dr. Manish Butte will be presenting the role of AI in the future of PI. We have 45 minutes allotted for this session, and we have to be strict about the time, like I said, for the other sessions. So we're going to keep everything running smoothly. If time permits, at the end of his presentation, we will take a few questions. I want to thank our generous sponsors for their support of their educational programming and community services. This particular session is supported by Grifols. Please note that the information presented during this session is not medical advice, nor is it intended to be a substitute for medical advice. This particular session, always seek the advice of your physician or another qualified health provider for questions concerning a medical condition. Immune Deficiency Foundation education events offer a wide array of educational presentations, including presentations developed by healthcare and life management professionals invited to serve as presenters. The views and opinions expressed by our guest speakers do not necessarily reflect the views and opinions of the Foundation. With that, let me briefly introduce our speaker. You can find his full bio in the conference app. Manish Butte is a physician, science, and leading expert in the field of primary immunodeficiency disorders at the University of California. He specializes in the diagnosis and management of individuals with various forms of PI. The Butte Lab focuses on T cells, investigating the genetic causes and pathogenic gateways of various concerns, infections, and primary immune deficiencies. Welcome, Dr. Butte, and thanks for joining us.
Thank you, Colleen, and thanks to the idea. I was going to make a joke about how many people I know in the room and how I've packed the room with all my friends. And then I sort of came to this realization that that's actually one of the things that drew me to the field of immunology, is that people become very close in our field. It's very collaborative, patients, doctors, advocates, parents. You end up getting to meet people over time and sticking together, right? This is one of the things that is so special about our community. And I think these kinds of annual meetings where patients get to meet each other, and especially the kids get to meet each other as they grow up, is incredible. So I'm happy to be here and grateful to have a chance to share a little bit of the stuff that we've been working on in my lab using AI, which is to say artificial intelligence. Our field has this problem that AI also means allergy and immunology. And so I have to sort of figure out how to talk to both camps with one acronym. But here, we're talking about artificial intelligence. And I don't have any relevant disclosures. The work that I'm going to tell you about was all funded by the NIH. As some of you know, I like to start with take-home points because I expect people's attention spans are, distracted by their phones and all these kids with their Instagrams and whatnot. But so I'll try to tell you what I want to tell you first. And I have definitely left, Colleen mentioned there should be enough time for questions. I've definitely left enough time for questions, but also if something you see on the screen is really burning and you want to just ask a question and not wait to the end, it's okay. This is your time. I'm here for you guys. So please just put your hand up for something and I'll try to call on you or just say, hey. Okay, so the take-home points are that we have figured out a way, and it's not just us, but now many groups are working on this problem, but we figured out a way how to find patients with PIDs or inborn errors of immunity. Hopefully all of you are familiar with the, there's no pointer up here, but hopefully many of you are familiar with the acronym IEI, inborn errors of immunity. It has really replaced PID or PI for many of us because we think of immune disorders as not just deficiencies, not just things that you're missing, but sometimes it's excess, overactive, too much, autoimmunity, inflammation. And so those ideas that there's a disorder of immunity, maybe it's a missing, maybe it's extra, that's captured in the term inborn error of immunity. And our problem that we're trying to solve is like how to find these patients, because they'll often go years without a diagnosis. And so we figured out a way of doing that. Using the electronic health records of our health system. Our hospital records has all the answers. And the key points that we were able to find are things like low antibody levels, but also a constellation of clinical features like autoimmunity and infections. And I'm going to try to show you that we can find these patients. I'm also going to show you that we have limitations, that we're not great at this yet. We're only about 2 or 3 years into this effort, and we have a long way to go, and we have some biases in the way we work that we want to try to fix. And so we're looking for help. We want to try to expand what we've learned at UCLA to other centers, especially into community doctors' practices, to try to make sure that we don't miss IEI patients anymore. So the goal is to try to explain to you what is the state of the art in using AI in identifying individuals from electronic health data, and then what all the issues that we still are left to tackle, the obstacles in the way. So one of the ways that I made this cartoon to try to sort of explain everything in one screen. But the idea is that we're going to take a patient database, like the UCLA database of all of our patients, and we're going to take from them all of our known bona fide, absolutely real IEI patients, the ones who have been seeing our doctors, have low antibody levels, have poor vaccine responses, their T cells don't work, their neutrophils don't work. These are bona fide patients. In the scientific literature, sometimes they're called ground truth because they're really the true IEI patients. And we can harvest from those patients data, from their record, features of their medical experience, how many times they went to the doctor, what their blood test showed, what their liver enzymes showed, what their blood count, all those things, harvest all that data, and then train an artificial intelligence to look for patterns. What are the features of these patients? These could be called warning signs. The models, were way ahead of the game coming up with this idea of what are the warning signs of immune deficiency. This is kind of what we're trying to find, or what are these warning signs that would tell you that this patient might have an immune disorder. Once we have that figured out, what we want to try to do is then apply it to the undiagnosed patients, the patients where we don't really know that they have an immune deficiency yet. And if we can try to pick them up after their onset of symptoms, but before they start getting really sick, maybe we can diagnose them early. Okay, so that is the overall scope of this project, is try to find patients using their health data, training on other patients and their health data to find the patterns that humans have a hard time seeing because there's too many patterns. As you all know, patients with immune deficiencies don't show up the exact same way every time. That's different from other rare genetic diseases. Like there are genetic diseases of cardiomyopathy where the heart muscle isn't formed properly. And those kids all show up roughly the same way. 1 week of birth, they start having this, 2 weeks of birth, so they'll have a very consistent pattern. Immune deficiencies aren't like that. Even though they're mostly genetic diseases, some patients will present at age 2 or age 2 months, and some people present at age 20 or 30 with very, very different symptoms. So the pattern matching is super hard for our doctors to get, and that's what leads to the long diagnostic delay. Okay, so the work I'm going to share with you was just recently published, just a few weeks ago, in Science Translational Medicine, and it's a group that myself and a computer scientist at UCLA, Bogdan Pacinoic, have led. We did this in collaboration with a group at Vanderbilt, and Vanderbilt University is now is part of our team. And the rest are all graduate students, which is awesome. We have started training students to think about inborn errors of immunity, primary immune deficiencies, as a worthy research project. And not just like their B cells and their T cells, but their data. Data science has become such a big deal in our world that you can actually get a PhD and spend your whole career academically studying data. And so we've started doing that. And then I'm also going to share a paper in a conference that we held last summer that we called AIPID, Artificial Intelligence and Primary Immune Deficiencies. And this conference was hosted in Barcelona by myself and 2 doctors from Vall d'Hebron Hospital and sponsored by many of the companies who are sponsoring this conference. Very, very cool meeting where we started to bring together all the people interested in using artificial intelligence. And we published the proceedings from that paper, from that conference in Jackie a couple months ago. Okay, so the problem we're trying to solve is the diagnostic delay. Many of you in the room, and if you're doctors, many of the patients you take care of, or nurses, if the patients you're taking care of spent too long to get diagnosed, 5 years, 10 years before they got diagnosed. That is a problem because they're getting sick during that time and they're accumulating damage to their sinuses, to their lungs, to their organs that may not be reversible. Once you put them on immunoglobulin or give them the right therapies, some of that damage is hard to undo. That's because of scarring. That's because we don't really know how to regenerate tissues yet. So once the injuries are in place, it becomes hard to back up. The other problem is there's a lot of costs involved. We know from many publications now, from the Models and others, that patients spend a lot of time getting scans and labs and surgeries and blood tests trying to figure out what their diagnosis is. And those add up and add up and add up costs. Once patients get a PID diagnosis or an IEI diagnosis, the costs come down because they're now seeing the right doctors. They're now not getting extra scans and extra tests. They're getting the right scans and tests. So we think that the health system will benefit from this by spending less in that phase of diagnostic odyssey. The other problem that we're trying to solve, so we're trying to speed up diagnosis. The second thing we're trying to speed up is, or make better, is to try to understand who gets sick from CVID and IEIs. There are some patients who just get infections and you put them on immunoglobulin replacement therapy and they do fine. They're able to have jobs and lives and children and careers and all that. And there are other patients who aren't. And Charlotte Cunningham-Rundles and now many others have published graphs that look like this, where the survival curve for patients with what's called complicated CVID is much lower than the patients who have infections only. Infections only has an almost great survival 40 years after diagnosis, whereas the ones with complications don't. So what is going on in these patients? They have more than just infections. They have autoimmunity and inflammation that leads to a lot of injury. And as much as immune globulin replacement therapy can fix the infection problem to an extent, some of these other drivers of morbidity aren't fixed as readily. They require a lot more interventional care, and some of these patients don't get it. So they get sicker and sicker. We want to predict who is on this curve and who is on this curve at the time of diagnosis. There can be some CVID patients who we could say, perhaps from our AI, be able to say, you're going to be sicker. Maybe you're the ones who we should push towards transplant earlier, or more aggressive immune suppression, or other options. And we don't know that yet. We don't have any crystal balls. So we're trying to build a little bit of a crystal ball to have some prediction capability. The last thing that we're trying to tackle is a little more theoretical, a little more conceptual. We have 520 genetic diseases that together are called IEIs now. And some of them affect B cells, and they're the CVIDs and the XLAs, and some of them affect neutrophils, and some of them affect CGD. There are so many disorders, 500 of them. But we know as doctors that there are patterns. The patterns are shared across patients, even if they have different genetic diseases. And it's becoming harder and harder to latch on to all the myriad of patterns. There's some patients who have T cell disorders, but also have problems with their intestines, with their digestion, and some don't. Some have lung diseases and some don't. Right? How do we build those patterns and the genes into some sense of which patients belong in which groups, so that we can not just call them CVID? Because I'm myself tired of calling everything CVID. I want there to be like names of things that actually mean something. These are the antibody deficiencies with the lung. These are the antibody deficiencies with the colitis. These ones should be seeing GI. These ones should be seeing pulmonology. Everyone should see immunology, right? That kind of like referral program doesn't exist. We really just ad hoc it every time. And I'm trying to build a sense of, can we understand the patterns of illness so that we can, and again, these patterns are way too complicated for humans to glean. I mean, these are too many variables. So we really need sometimes a little bit of help. Okay, the problem arises oftentimes because as much as we are lucky that Americans get access to healthcare, we find ourselves doing a very organ-specific healthcare in America, which is like, if you have a joint problem, you see a rheumatologist. And if you have a lung problem, you see a pulmonologist. And if you have colitis, then you see a gastroenterologist. And these doctors put on their blinders because they have tunnel vision, and they take care of your colon, and they take care of your lungs, and they don't think about the underlying underpinnings of the disease. Is there a B cell defect that could explain all of this? They're not thinking about that. In fact, a great example is in the IBD world, the inflammatory bowel disease world. They call arthritis that occurs in patients with IBD. They call it an extra gastrointestinal manifestation of IBD, which just means we don't understand, but it's outside of the GI tract, right? They're not thinking that there's an underlying immune disorder causing both. That doesn't come up for them. They're just saying, this is part of your IBD, it's just not in your colon, right? And that to me is like, wow, think about how much we're missing because we're not able to educate the GI docs to think deeply. Okay, so your answer should be, well, Manish, go out there and educate the GI docs. And that was our program. For the last 20 years, many of us in this room, went to pulmonology clinics, went to GI clinics, gave talks to these doctors saying, here's what an immune deficiency looks like. And, they're on their phones and they're closing their notes and they're doing the other things because they're busy doctors. And it's hopeless, okay? I am officially declaring it hopeless to educate pulmonologists. Okay, I'm picking on pulmonologists. All these other doctors are busy, and especially the surgeons, they're not going to have time to listen about my 500 genetic disorders and how the B cells and the da-da-da, they just don't care. So how are we going to get the pulmonologists to listen to us? We're not. But what we can do is read their records and read their notes and have our AI look at their charts and say, oh, this patient, this one has an immune deficiency. I don't have to teach the pulmonologist anything. We're going to go ahead and figure that one, right? So that's our idea now, is to move beyond educating the masses because it's hopeless. One last thing that this problem arises in, again, unlike like the genetic cardiomyopathies and the genetic other diseases that are in our rare disease camp that we are brethren to, those diseases often have one gene associated, like long QT syndrome has one gene, and if you could find that gene and sequence that gene, then you made the genetic diagnosis. And it doesn't work that way for us. Again, we have 500 genes, many, many presentations of those disorders. So there's no one mechanism that you can track down with a single blood test. We need to have pattern matching around their clinical symptoms more than anything else. Okay, to remind you, CVID means you have to have hypogam, you have to have no other explanation for the hypogam, you have to have poor responses to vaccines, you have to be over age 2, and you should not have an associated T cell defect. Otherwise, it's a combined immunodeficiency and not an antibody deficiency. This paper is meant to show you how many groups are working on this problem right now. So this is our paper. It just came out, as I showed you, about a month ago. And these are all the other papers that have come out in the last 3 years. You can see how many papers, how many groups around the world are now working on artificial intelligence and pattern matching and finding the IEI patients. This is becoming an academic area of interest. It's super fun. And I've gotten to meet all of these groups. The first group to really come up with warning signs for IEIs was the Models. Everybody here is familiar with this. And I'm very sad that Vicki passed away earlier this year. I got to go to her memorial service. And we talked about, in the gathering afterwards, we talked about how the warning signs really catalyzed our field into thinking about who has an immune deficiency. It's on park benches, it's in airports, it's everywhere. But it misses a few things. And I think this is the area that we're really trying to add on to. There's nothing wrong with these warning signs, but it misses autoimmunity, severe allergic diseases some of our IEI patients have. It misses the periodic fevers and autoinflammation. It's mostly focused on infections. If you notice here, infections, antibiotics, infections. It's mostly infection. And that was our world in the 80s, right? I was actually still in med school, but that was the world that Vicki and Fred had to tackle back then, is to come up with warning signs around this. Okay. Teaching an AI to recognize immune deficiencies is like teaching med students and residents and fellows. The more examples and cases you can give them, the more they're going to glean from it. And if you go to some allergy and immunology doctor who says, oh, I'm trained in allergy immunology, but I've only seen 2 cases of PI, you know what those doctors are like. They don't really have a lot of patterns to match. They've just seen 1 or 2 cases. But if you have someone who's seen 200 or 500 or whatever, you're going to get someone who has much more breadth and much more nuance around each case. So we did that. We realized we had to train our AI with a lot of cases. We ended up finding 186 patients with CVID at UCLA. These are bona fide. I myself went through the charts of all of these ones, and they have very different patterns. Some were picked up at age 8, some were picked up at age 38. This is the ages of our patients as of a year ago. So you can see a bunch of kids and a bunch of adults. And sometimes people say to me, like, why are you seeing 40-year-olds in your clinic and 50-year-olds in your clinic? You're a pediatrician. But that's what we have to do in immunology is we see, because the 50-year-olds were once 5-year-olds, right? And we have to see them throughout their spectrum of life. But this is the data that we trained our algorithm on. And I'm going to skip over that and just show you, this is what our cohort looks like. Some of our patients have lymphadenitis, some of them have fibrosis, some of them have low platelet counts, big spleens, big livers, skin autoimmunity, low blood count, colitis, sinus infections, pneumonias. Many of you in the room recognize these symptoms, these diseases up on this axis here. And you can see these are our 186 patients. There is no one pattern here, right? Every patient doesn't have the same thing. The one that you can see runs across the gamut is chronic sinus infection. Almost everyone has it, but there's a bunch here who don't. A bunch of bronchiectasis, but a bunch don't. If you were going to try to train someone and say, this is the one thing to look for, man, look for bronchiectasis, it doesn't work. You're going to miss a third of the patients. That's part of the problem we're trying to tackle is what are the patterns you can find? The ones who have bronchiectasis also have thrombocytopenia. Maybe that's a pattern, right? Do you get the idea? And if with too many variables, no human can find the patterns here. That's why we have to use algorithms. So we take our patients and we match them with other patients in our health system who are roughly the same age, roughly the same sex, roughly the same self-identified race and ethnicity, roughly the same amount of data in the health records. And we put them, 1,000 of them, and we mix it together and ask the algorithm to learn which ones have CVID and which ones don't. And we hide some data and we do all the right things data-wise so we can get the right answer. And the training that we're doing uses a lot of data tools like inference networks and phi codes. And we ended up coming up with a way of doing it. And these are the phenotypes that it ended up catching on to, saying these are the most important ones: anemia, adrenal disease, bronchiectasis. So these ones are all enriched in our patients over the background level of CVID patients. And some of them are like 20 times more frequent in our CVID patients than are in the background. Some of these ones are linked in this online Mendelian database that many geneticists use, but you could see many are not. Like pulmonary fibrosis doesn't appear in OMIM anywhere. It would be missed by a typical genetics sequencing group. If they were going to look at pulmonary fibrosis as the phenotype, they may not catch that that's related to an immune disease. But our AI can catch it. So does it work? Can we diagnose patients early? I'm going to show you how. Yes, the answer is yes. And I'll show you how it works. So imagine a patient. This is a hypothetical patient who today, if we were to open up their medical record and say, what kind of infections and autoimmunity have you had? Well, we could say this person has had 1, 2, 3, 4, 5 sinus infections, 2 pneumonias, had chronic diarrhea, and had an autoimmune hemolytic anemia and immune thrombocytopenia. All of those are in their record. And if you looked at this, you'd be like, oh, duh, of course this patient has an immune deficiency. They have infections, they have autoimmunity, yes. So if you were to look at all of the records at once, you would have the answer. But that's not the way patients present. This is the way patients really present. What have I done? Okay. No. Sorry about that. So this is the way they present. They start off 5 years ago with ITP and a pneumonia. And then maybe 1 year later, they have a sinus infection. And then they have a pneumonia. And then they have a sinus, right? This is the more typical course, is where there are a series of events that occur over time. And that series of events, if you look at it all in aggregate, yes, it makes sense. But at what point in this chain of events would you make the diagnosis of CVID? Would you suspect CVID? Would it be here after their first sinus infection pneumonia? Would you be like, oh yeah, that's a CVID patient? Probably not, right? Probably not. It takes a series of things before people start pattern matching. And in fact, in this patient, for example, they might have been diagnosed way out here after their third sinus infection and second pneumonia. That's much more typical. This is what creates the diagnostic delay, is that patients have to go through a lot before somebody says, wait a second, maybe you're one of those weird, rare immune deficiency patients. This is a much more typical course. So we want to be able to ask our algorithm to find these patients, not by looking at all the aggregate data, because it's a little bit easy, but instead say, okay, let's go back in time 5 years ago and give you these 2 things. What do you think now? Do you think this person has a high score? Are they likely to get into the red zone for CVID? Maybe not. Okay, how about now? We'll add one more thing. Okay, we'll add more things. We'll add more things. At what point, going back in time and hiding from ourselves all the things that are going to occur in the future, when does the algorithm say, oh, now I think it's a CVID? So that's what we did to our algorithm, and we put it to the test by adding on more and more data and asking at what point does it feel like there's a CVID diagnosis. So if we hide data from the algorithm, it does worse than if you show all the data, of course. The more you hide from something, the worse it's going to do. But it wasn't that much worse. And so we had some faith in this idea. And so we ended up taking 56 of our 186 patients who had 8 years of data and lots of medical records and lots of lab tests. We felt like these were ones that we could really test our method on. And we went back in time, just as I showed you. And some of these patients, we would have picked up, so this line in the middle of the screen is their moment of diagnosis, and each dot is a patient. So for example, this patient was diagnosed at some point, and this patient was diagnosed at some point in time. And their moment of diagnosis, if you take like January 4th, 2021 for this patient, we call that here, and maybe March 5th, 2018 for this patient, move it here. All of the moments of diagnosis are lined up here. This is 1 year later than diagnosis, 2 years later, 3 years, and 1 year before, 2 years before. So our algorithm would have picked up all of these patients, of these 56 patients, prior to them becoming clinically diagnosed. About 2/3 of the patients we could have picked up, in some cases, a year, 2 years, 3 years, and 4 years before they were diagnosed. So this is a big win for us. We want to do better than this. We want to take it to 5 and even 10 years back. Right now, our electronic database isn't big enough. UCLA switched over to Epic about 13 years ago. So we don't have that much, no, 11 years ago. We just don't have that much data in hand yet. But as time goes on, we're going to be able to test this more and more. This is still a big win to be able to diagnose patients a year ahead of time. This is a typical patient. So they had lymphadenitis, they had asthma, they had some sinus infections, they had bronchiectasis, and then somebody diagnosed them with CVID here, middle of 2015, 2016. But if you look here, our algorithm picked up that they were likely to have CVID back here. Back when they had this sinus infection and this bronchiectasis, the algorithm score pinned up and said, wow, this patient is very interesting. This one's likely to have CVID. So we would have picked up this patient about 6 months earlier than they got diagnosed. I'm just showing you like a typical case. Okay, can we find new undiagnosed patients with CVID? I'm totally not looking at the time. How bad am I? Keep going, okay. Another hour? Oh, good, thanks. Thanks, Helen. Okay, so how do we pick up new patients? We took the entire database and we trained it on our patients. And then we ran our prediction model, right? And then what we did is we said, let's see if we could find other CVID patients who haven't yet been diagnosed. So we ran our prediction model then on 1 million patients at UCLA. And those are patients who have had at least 2 visits at UCLA, and not just for blood draws. They have actually had to see doctors. And we calculated the scores based on the algorithm, and then we took their charts and we gave them to a clinician. These are our clinical fellows. And we gave them 100 charts that were age matched and 100 charts that we identified with this algorithm. And we blended them together, and we gave them 200 charts and say, of each of these 200 charts, tell us if you think this patient is likely to have CVID or unlikely to have CVID, right? Okay, so 200 of them, they better be able to say, oh no, that's not CVID. Those are random patients that you picked up. Does that make sense? But we blinded them, so we didn't tell them which was which. And this is what we found. In the random 100 patients, our fellows said, these patients nearly certainly don't have CVID, right? Because they were controls. So it works. Our fellows don't accidentally diagnose patients with CVID. But of the top 100 patients, 60 of them were possibly to have CVID, and another 30 were listed as likely or definitively have CVID. Definitively means that they had hypogam on a blood test. They had, actually, many of them had B cell counts too, abnormal B cell counts, but nobody diagnosed them with CVID. I mean, it's amazing to me that these patients exist in our health records, and they're just waiting for someone to tell that pulmonologist that they have to, okay, so. The pulmonologists get a bad rap in my, and these are the top 100 patients. They're screaming hot across all these different things. Remember, these don't have immunodeficiency diagnoses. These patients don't have immunodeficiency diagnoses. Bronchiectasis, pneumonias, diarrhea, airway obstruction, pneumopathy, blah, blah, blah. So you see, these patients are pretty sick and they don't have a CVID. I mean, so this is what we're waiting for, is to find these patients, bring them into immunology clinic, and start doing the genetic and blood tests and see if they have CVID. because they've eluded diagnosis so far. These were the match controls. Any first-year fellow or even first-year medicine could realize that these are not CVID. Okay, one criticism we got when we tried to publish this is, does it work elsewhere? And so we externally validated the algorithm that we trained at UCLA on the data sets at UCSF, UC Davis, UC San Diego, UC Irvine, and Vanderbilt. The data was trained just on UCLA and then applied to these other data sets. So there are different populations of patients. Some of these areas have very, very different demographics than other areas, right? And that was one of the criticisms that we had to be able to overcome. Vanderbilt has a very different demographic. We were able to find still many of the patients in the top 100 had a diagnosis of CVID already. That was one of the ways that we could find these patients to figure out if our algorithm is getting it right or not. We now have formed, this is part of the grant that I have with the NIH, all of these sites, Morna Dorsey at UCSF, Victoria Dimitriadis at UC Davis, Hal Hoffman at UC San Diego, and Sudhir Gupta at UC Irvine are now, and me, we all have immunology clinics where I am referring these top 100 patients to their immunology clinics to be seen, okay? So we are going to try to catch hundreds of CVID patients who have missed diagnosis, who have not yet been diagnosed. And I'm hopeful that we're going to be able to do this all in the next 2 or 3 years and publish another paper and really try to change the field. Yeah, okay, so this is, for example, UCSF's top 100 patients. So many of them have thrombocytopenia, many of them have pancytopenia. UCSF's data set turns out to be a lot younger than ours. We're learning a lot by working beyond our own borders, going to more and more hospitals. We've actually started training the next generation of algorithm on UCSF's CVID patients and on all the others. So we're really broadening our AI's reach. Okay, here are the problems that are unsolved. Colleen, how many minutes do I have left? That looks like 14. Okay, good. One of the problems is how to process the data to train the algorithm. Making the health records readable for computers is hard. Frankly, health records are hard for doctors to read. So how the hell is a computer going to read all this? It's super hard. And there's a number of groups that are work on what's called harmonization, where all the data is brought into a computer-friendly format. Eventually, the computers will have our jobs, so we need to make their lives easy as they supplant us from this field. And so we're using something called phenotype codes. Other groups have used something called HPO codes, and these different groups allow us to simplify the records in a way that the computers can read. Infection frequency, as I pointed out to you, is a major warning sign of CVID. Our algorithm needs to learn how to look at frequency, but we don't have this problem solved yet. Here's a fake medical record where this is time. Each one of these dots is an encounter for a single patient. And here is in that encounter if they were diagnosed with a sinus infection or not. For example, the patient came in and they were diagnosed with a sinus infection and their record was stamped with sinus infection as in their record. And then they came in again, and then they came in again and it was not. And then they came in again. Okay, so if you looked at this from afar, you might say, this is 4 sinus infections, you dummy. Here's one, here's one, here's one, and here's one. 4 sinus infections, right? But what if these infections were only, what if these 2 encounters were only a week apart? 1 week apart, it's probably the same sinus infection, right? It's not a second sinus infection. So how do you teach the computer to see 4 records that say sinus infection and call that only 2 sinus infections, right? Does that make sense? That's hard. We have not solved this problem. We are still working on it, and we don't have it solved yet, but we have a number of ideas. Like sometimes you run into this, where they came in 4 times for the sinus infection in the course of a few months, but then once they didn't. And then we have to dive in and say, oh, this is when they came to the emergency room with a sprained ankle. And the doctor didn't ask about if they had a sinus infection. So that's why it didn't appear in the record. Does that make sense? So we have to like clean up the data in a way to help the records sort of be enriched. And this is really hard stuff. So one of our clinical fellows, Aaron Chin, this is his project. He is working on this right now, trying to write code to teach the algorithms how to discern how many infections someone has had. Because the models were right 30 or 40 years ago. Infection frequency is super important, and we can't afford to miss it. We have to be able to build that into our system. Another bias that we've run into is age. We see a lot of patients over 55. We're missing the younger patients. Our algorithm does worse on younger patients, so we need to do better for that. And then all these other disorders look like IEIs, and we need to figure out how to discern IEIs from these other disorders. Okay, I'm going to come to the end here. We're hosting a meeting next year in New York City, sponsored by IDF, Jeffrey Modell Foundation, IPOPI, those three advocacy groups, and then also by a bunch of companies. And we're very excited to have patient groups being present to these meetings. It's super important for us to be able to get patients involved with us, with our work. As we build algorithms, we don't want to leave people out. We want to make sure everyone's included. And so, if you have anything to contribute, please let me know. I'm super happy to be here. My email's at the bottom. Thank you. Sorry, Colin. I went over.
You're fine. Don't go anywhere.
Okay, questions.
Yeah, we're going to get to that. So thank you, everybody, and thank you, Dr. Pugh. That was amazing. So real quick, we're going to have the resources up here. You can click on the QR codes, and I'm going to talk quick so we can do a couple questions. The top one is Ask IDF. That's sort of the hotline to IDF. You can go to that. You can ask any question. We will help you. We will get the resources, whatever you need. The other one is our IDF Get Connected groups. If you are unfamiliar with those, they are support groups throughout the entire United States. They are run by patients who have either disease-specific groups or regional groups, state groups. There's professionals with PI. There's parents with PI. There's all kinds of groups that you can join, and you may join multiple ones if you would like. So those are two of the resources. We have a whole lot on the website, and I encourage you to go and look. The other thing is please fill out your conference session survey on your app. That way it lets us know whether you did a great job and whether it met your expectations so we can plan again to do this again in 2 years. With that, I'm going to come down and ask anybody have any questions, and we will let him answer. I assume there's one, right?
Go ahead. Over here?
Hold on.
Oh, yeah. Great.
I'm all on myself. Okay.
5 stars, everyone.
Well, thank you very much for this presentation. Wonderful. I saw that you were talking about the different things that you're being able to incorporate and when you talk about the next 2 or 3 years, what you're doing. So I'm in a lot of the connected groups. I'm also involved with other medical organizations. And one of the things that we've been finding, and I'm talking with other people here too, the comorbidities. And how we're wondering if it's more of like a over because you know that there's not just infections and gastric problems, but there's also neurological manifestations and all these. Are you or other doctors out there looking to maybe use it other things to try to incorporate other things in? Because other doctors who treat neurological problems or other types of problems out there are not sending their patients to be tested for PIs. Yeah. And the PI doctors are not looking into the other problems, and maybe there's some more incorporation where they're more the same.
Yeah, that's a great, and it's a point that I'm glad you're echoing it because it's what I mentioned earlier on is that there are doctors who are seeing PI patients. All those patients who see at UCSF, UCLA, et cetera, are being seen by doctors. They're just not getting diagnosed. So what is holding them back is oftentimes this tunnel vision. If there's a neurologic complication and they're seeing a neurologist, they're not getting that referral to immunology because the neurologist is focused on those brain symptoms, right? That is our problem in the American healthcare system is that we don't have that sort of broad view anymore. We've built a highly specialized health system that can dive deep into problems but doesn't step back. It's a problem that we're not going to fix by educating neurologists about PI. We have to be able to use another method to reach into the neurologist's notes and pull out the interesting patients. Wait, sorry, go ahead.
What I think she's asking is, are you with your project looking at other?
Oh, yeah. We're looking at, yeah, so for example, the 1 million patients that we looked at UCLA, we're looking at all of their notes. Every single clinic visit they went to, they weren't seeing immunologists. So they were seeing hematologists, rheumatologists, gastroenterologists, et cetera. In fact, the pattern itself is interesting. We have found, I haven't shown the data for this, but we have one of our postdocs working on this where she has found that the pattern of older patients, 30, 40-year-olds, as opposed to young kids, often will go from a gastroenterologist to immunology or pulmonology to immunology, whereas the younger patients go from primary care to immunology. And that pattern itself is interesting because it might be the first place that we reach out to be able to say, can we work with you guys for the more severe IBDs and walk you through some of the genetic testing and immune testing, right? So even knowing the pattern of referral, how the patients, not referral, but how they actually march their way through the health system before they land on a CVID diagnosis. As we go back in time in that process, we might be able to get to, and that's what we're trying to get to, the clinics that we should be targeting first. On that list isn't neurology, it's GI and pulmonary. Yeah, oh, yeah, go ahead, whoever. Colleen's got it. This, by the way, is the team working on it. I just like to give credit to the people who are doing the work. Epic is one of the ways, Cerner, there's a couple of health systems, EHR systems out there. The Epics all can talk to each other at a level called Care Everywhere. And they allow, that's how we can see all the other sites, notes, and things like that. But we can't mine data through Care Everywhere right now. And it's a major problem, right? Because our patient might go to urgent care and get diagnosed with an ear infection and get put on amoxicillin, and that ear infection never shows up in our record. At which point we don't think that they've had that ear infection. We just know about the ear infections that we've seen. So we are very much hindered by this discrepant data. There are other countries that don't have this problem. Canada, for example, and other nationalized health systems have the ability to see each other's data in a unified fashion. We're not there yet in America. We definitely need to do something about that if the rare disease populations are going to benefit. Epic has shown some interest in this, by the way. They have a small group that is working on rare disease that has been able to reach through to other data sets. But at the risk of time, let me just give you an example of why it's hard. Because if two institutions, say Stanford and UCSF, 30 minutes apart from each other, are taking care of rare disease patients, and if they can see each other's data for the purposes of building more knowledge about a rare disease, that's great. But if it's used in a marketing fashion, like, oh, we can see that at UCSF, half the patients with, CVID have this complication, have died or whatever, right? Whereas then they could put up a billboard. Stanford could put up a billboard saying, if you have a rare disease like CVID, don't go to UCSF, half their patients die. And that's not libel because it's true. At which point, who is going to share data regardless of how much it can help? And I'm not making this up as a hypothetical. When I was a faculty at Stanford, I had this exact phone call with Epic. And they told me exactly this example. They said, we can't share data across institutions because it could be used to market against each other. And I was like, but we're trying to help rare diseases. And literally this is a problem with sharing data, is that it can be used in an adversarial fashion. I know that doesn't occur to all of us, but sorry. Oh, did you have a follow-up on that, or? Yeah, I'll repeat her question. So she said, can patients give permission to use Care Everywhere? And in fact, in the international world, people have surveyed rare disease patients about their privacy desires versus non-rare disease patients. And rare disease patients in general have more of a willingness to share their records than not, because they know that if you don't, you're never going to learn anything, right? There's only a couple of this and a couple of that. Even at big institutions like UCLA, how are we going to learn anything if we don't share with each other? So rare disease patients are more willing to do that, but we don't have a legal infrastructure for that yet. And Epic doesn't either. Sorry. Yes, Roger, go ahead. Dr. Koyashi. Thank you. Thank you.
Just a quickie, data mining. The question I had is what about the confidence? You started internet.
Yeah.
About 25 years ago, we had somebody came, a computer would automatically screen all of the infections and so could you do something like that to scale the emergency? Somebody comes home with an ear infection, the computer automatically screens.
Yeah.
These patients out because we have the
100% yes. Here's the problem with it. It's something called alert fatigue. That if you put up an alert in an emergency room doctor's face who is crazy busy saying, this patient may have one of 500 genetic B-cell disorders, they're going to be like, how do I cancel this box as fast as possible? Right? Cancel. So we have not yet figured out how computers can talk to doctors. Go ahead.
I agree with you. It's hopeless to teach other specialties. I thought it 30 years ago. What I was thinking is that the thing automatically does it.
Yeah,
The computer automatically kicks the thing out.
right.
Take the doctor, the emergency room, the surgeon completely out.
Yeah. You're talking about the idea of the emergency room system saying, this patient's likely to have an immune deficiency, I'm going to order IgG levels and a B cell count, et cetera, without having the doctor do that order. There's some people in the room nodding because it's the right answer to some people. And for other people, it takes away the autonomy of a doctor to make a decision, and it adds cost to the health system, and it could be used against, like there's a lot of stuff as part of that sort of the computer can make decisions for us that we haven't grappled with yet. I think some people in the room would be happy to sign over their medical records to the AI. I'm a little bit mixed because I can see it can be used in the wrong way too. But yeah, you're right. If the computers could do the orders for us, we would solve that. We'd solve this problem too. Okay, Colleen's mad at me, so I should stop talking.
I'm not. It was wonderful. Thank you. Thank you, everyone, for being here. And if you have questions that were not asked or answered, Ask IDF is the way to go. And I hope you enjoy your conference. And please don't forget to fill out that session survey. Thank you.